Hello everyone, and welcome back to a brand new season of Case-Based Learning with Expert. I am Christina, a member of the Academic and Research Bureau of the Malaysian Dental Student Association of 2023 and 2024 tenure. So today we are at the Faculty of Dentistry of University of Malaya for our first episode of this season. We are honored to be joined by Associate Professor Dr. Lim Ghee Seong, who is a respected lecturer and clinical specialist in prosthodontics at here. So Dr. Lim himself is an alumni of from which he graduated with his bachelor's back in 2008 before going on to pursue his master's in Newcastle University. Among other outstanding positions, he is also currently the examiner for the Restorative Specialty Membership Examinations of Royal College of Surgeons, England. He is also the Assistant Secretary for the Malaysian Association of Aesthetic Dentistry, as well as the Vice President for the Malaysian Association of Prosthodontics. So come with me and let's meet our expert of the day, Dr. Lim Ghee Seong. Good day, Doctor. Thank you so much for joining us today. We're so lucky to have you on board with us. How are you feeling today?
Today, I'm good. But first of all, I would like to express my appreciation and thank you for inviting me to your interview. So I'm feeling good and excited to share a few cases with you all later.
Alright, good to hear that. So before we get into the topic, would you please tell us a bit about your background and how you got into prosthodontics and restorative dentistry?
Alright, so I first graduated from Universiti Malaya, 2008. Then after working 5 years in government, Ministry of Health in Kelantan, I was given the opportunity to study abroad by University of Malaya. So I went to UK for my master's and came back around 2016 as a lecturer. So my main interest is actually in removable prosthodontics. And we know that restorative dentistry, prosthodontic is one of the components in restorative dentistry. So that's the reason now I'm in restorative and also in prosthodontics.
I see.
Yes.
Thank you so much for sharing with us, Doctor.
Okay.
I heard that you have some interesting cases to share with us. So without further ado, shall we get into that?
Yes, actually I have difficulties in selecting what type of cases to showcase to you all, which is suitable to undergraduates or even other dental clinicians that might be interested. So, but before we go into depth, the cases, one thing that I would like to remind everyone, where I always reminded my students, we have to treat the patient in a holistic approach. Holistic approach is, we know that the dental health is related to general health, your social well-being, your quality of life, and even your emotional health. So we have to treat the patient as a whole, as a human. Not like the patient complain toothache, you just treat toothache and then just bye-bye to the patient. No, we have to look at the whole, what type of problems, other problems that might have, we're going to treat it as a whole human, like holistic approach. Okay, so let's look at first case.
So for the first case,
Yes.
Could you briefly describe the case?
Alright, cool. So this first case is more to hypodontia case, where we are going to see how we are going to manage this hypodontia case, be it conservative dentistry and also prosthodontics. Actually, for this case, we have patient's 25-year-old male with insignificant medical history and dental history. That means patient is fit and healthy. So, however, patient say that he is a smoker who smokes 10 to 15 cigarettes per day. But he told me currently that he switched to electronic cigarettes. That means he's doing vaping now. But we have also actually informed the patients, actually there's no difference between conventional and electronic cigarettes. All has its own effect. And also he also said that he drink alcohol occasionally. Diet history wise, he said that he likes favorite drinks, favorite water and fizzy drinks. He drinks almost every day. So that is the important point we have to note. These two, smoking, alcohol and diet. Let's look at the complaint. So his main he's concerned about lack of teeth. That means the appearance. And also he complained that he cannot eat the food that he wants, normally the hard food, like apples and all the other fruits. So for his history of presenting complaint, his permanent teeth was absent after the primary teeth exfoliated. Okay, so this gives us a sign already. Most likely it's hypodontia. And the problems that with eating and appearance started after a few of his permanent teeth was extracted due to caries. Again, it also ring our bells that this person has high caries risk. What type of information we can get from this history of presenting complaint is, we know the patient's priority is functional eating and also aesthetic, the appearance. So all these things were related to the examinations that we are going to carry out to gather more information. So we have performed extraoral and intraoral examinations. Extraoral show nothing significant, all normal, other soft tissue normal. But intraorally, when we check, the oral hygiene is fair, but it has mixed but depleted dentitions. That means the teeth are very depleted or very lacking. That means only a few teeth left. Patient was presented with class 3 skeletal profile and also has his lower primary dentition remain, mainly 81, 82, 83, 73, 74. That means patient has this deciduous teeth left. So what we need to do that rings in our mind is later we will definitely need to take radiograph, okay, to determine whether there is permanent tooth or not underneath those retained deciduous. So these are the things that will actually give us a clue what type of further investigations that we need to do, all right? And so besides that, you also noted a lot of caries, multiple caries, which include 81 distal, 36DO, 46DO, 37 mesial. And also there is 17 retained roots. And BPE score show the highest score 2, mostly all on the section of the lower teeth. Because of the caries and the large restorations, we have ordered a few pulp sensitivity tests on 18, 37, 46, 34 and 36, 34 as a control. So we do CO and EPT tests. And the result shows that other teeth are apart from 36. 36 show negative CO results and EPT showing just a little bit slight response only on the red color side. So we can conclude that 36 most likely is non-vital already. Alright, the rest 18, 37, 46 is still vital. You will see later, I will show you the photo of the lateral view of the clinical photos. You will see that the patient actually has problem biting because on the whole arch, it's only one tooth that is supporting the whole occlusion, which is the 18. So therefore, we have undergone occlusal examination, which review actually, yes, 18 there is occlusion, the only occlusions, but also 18 is actually the interference to the occlusion that makes the patient, when it bites down, it makes the patient always posture the mandible forward into class 3 relationships that we see in the scatter profile. And then we took a DPT. We see that there is minimal horizontal bone loss, but multiple caries noted that the teeth that I mentioned just now, 18, 36, 46. You can see there is a radiolucent on those areas. And then also there is deciduous teeth presence, the 81, 82, 83, 73, 74. But if you see properly, there is no permanent teeth present underneath the bone. So that is the summary of our radiograph findings. So with all this information, we can come to the diagnosis where a patient is having hypodontia, plaque-induced gingivitis, dental caries 1846. 36 already pulp necrosis because of the pulp sensitivity test. When we look at the x-ray just now, it's already subgingival, so it's unrestorable. 17 retained roots, and also generally there is depleted dentition with loss of vertical dimension and occlusal instability. All right, so that is the diagnosis.
Very interesting history. And thank you, doctor, for telling us. So for the next question, could you guide us through the available treatment plan for this patient, and what consideration would you take into account when designing an upper and lower removable prosthesis for this patient?
All right, that's always the good questions. But before that, we have to differentiate what do you mean by treatment options and treatment plan. Okay, treatment options is the options that is available that we can utilize or we can prescribe to the patients. But the treatment plan is the one that we're going to execute for the patients based on the patient's preference, financial status, and also the oral conditions. All right. So let's talk about treatment options. What options do we have in these patients? You see with depleted dentitions, with multiple primary teeth present, the deciduous teeth, and multiple caries some more, and also retained roots. So how here? It seems very complicated, but actually when you break it down fraction by fraction, it will be easier. So how we can break it down? We can break it down actually two. One is preliminary treatment. Preliminary treatment is mainly to stabilize the condition first. What do you mean by stabilize? You see, got caries, got burial conditions. We want to stabilize all those. Then we move to the second one, which is the definitive treatment phase. Definitive treatment phase normally involves prosthodontic approach. Let's talk about preliminary first. So preliminary, what we can do is, normally we can do diet counseling first. We know that he likes flavored water and fizzy pops and drinks every day. These fizzy drinks, if you drink every day, first cause caries, second, tooth wear, all right, erosions. So we need to have proper diet counseling, then followed by oral hygiene instruction and smoking cessations. All these are still stabilizations, and we want to prepare the patients to do for much complicated prosthodontic treatment later. Besides that, because patient has gingivitis, so we can treat the gingivitis by non-surgical management, or nowadays we call it PMBR. PMBR is a new term for non-surgical management of periodontal conditions. We call it professional mechanical cleaning. Then after that, after the gingiva already stabilized, then we are going to do restorations. If you don't have time to do all the restorations, you can do temporizations of the carious tooth. Once that's done, then all the teeth that needs to be extracted, you can extract, and then you can consider for what we call interim prosthesis. Later, I will tell you why we opt for these patients and the treatment plan. What's the reason behind it? Because I think you all might be interested why we go for interim first. All right. So let's go to definitive phase. This is still in treatment options. You can go for full acrylic upper lower or cobalt chrome upper lower. All right. Or you want to go for dental implants or implant retained prosthesis. For example, if you go for all on 4, then you want to bridge or dentures over dentures. All right. So in this case, what we do for the patient is, so first, again, we do stabilization space, like I said just now, which reinforce oral hygiene, diet counseling, smoking cessations, and then non-surgical management of the perio, okay, and do all the restorations that still can be restored. Then extraction of 3/6, 8/1, 8/2, 8/3, okay. We decided to choose a few to extract, not all. The reason we still remain a few of the deciduous teeth is, when we check the x-ray, it's still robust. That means it's not shaky. I mean, it still has sufficient bone. And you know that patient is hypodontia. There is no more permanent teeth coming out. So that means we want to retain the deciduous as long as possible. Why? Because we want to maintain the bone level. Remember, when we extract the teeth, what happened to the bone? The bone will resorb. Okay. After that, we prescribe with an interim prosthesis or temporary dentures to the patients. The reason why we do all this is, actually patient tell us that he is going for an interview, for a work interview, and he needs the prosthesis really quick. So if you want to wait for the conventional complete denture, you need to wait for the healings after extraction, and then wait for the cobalt chrome to be processed. All takes time, but patient don't have any time. So, and patient, remember the patient has the 1/8 interference. We don't want to go so fast into the definitive phase because we are going to incorporate the interference in our prosthesis. Okay. Therefore, we come to the conclusion we only give temporary dentures to the patients. After a few weeks, we review first before we take the impressions. Later, you can see the photograph. After the review, you can see that the gum, everything is already nice. That means no gingivitis, patient able to control the blood control very well. Then we give the interim prosthesis. So then you can see after the treatment, you can see that the patient now has full dentition. Okay, and then patient actually came back to us saying that he finally got the job. Okay, after wearing our dentures to the thing, because it will increase the self-confidence, the self-esteem. I think that helps a lot. That's why we see it's holistic. That means it will affect the patient's confidence level, emotional health. Therefore, I think this is quite a good outcome before we can wait for the patients to decide on when to get the definitive treatment. Because this is just interim. Sooner or later, the patient will need to come back to get the definitive treatment.
I see. Thank you, doctor.
Yeah.
So the next question is, what's the rationale of keeping the tooth number 1/8 instead of extracting it, since it was interfering with the patient's occlusion at first?
Yes, that's always the gray area, especially for this type of case where the 1/8 is the only contacting tooth. That means it's the only tooth that is held out the patient's occlusions. And then a few considerations that we should actually think of. First is whether patient is comfortable or not in this position. Because a lot of patients, when they are already comfortable with even with interference, to them it's not interference. To us, maybe we saw it as an interference. So this group of patients has been living with this interference for so long, and it didn't affect the other dentition. So most likely we are going to retain or incorporate the interference into the new prosthesis. It's for the patient's comfort because it doesn't affect the restoration of other teeth that is present. So that is one reason. Another reason is when we explain to the patient, okay, when we do an occlusal adjustment, because this case, yes, you can correct it by doing some occlusal adjustment. For example, you do occlusal equilibrium. That means you can trim off or you can crown the tooth into the ideal positions. However, when we explain to the patient that the patient needs to go for rehabilitation, adaptation, and all those, patient is unwilling for this case. Patient said he's comfortable with this position and he's not willing to go through all these complicated treatment because at the moment, patient is not having work. That is before the interview. So financial constraint, patient said he's okay to live with the interference. Therefore, we decided to just keep the interference and build the restoration around that. Yes.
Very insightful, doctor.
Yes.
And the next question is, what's the rationale of doing an immediate denture instead of waiting for the socket to heal for this patient? And is it suitable for every patient?
Yes, in this case, because patient, I say, is going for interview, right? Can't extract teeth and then wait for healing because of the empty space and all those. And then one consideration also is not for every patient. The indication is patient must be healthy. That means fit and healthy, no medical history, nothing. Why? What's the reason of this? Is because when we extract the tooth, right, the socket is to undergo healing. For example, if you have uncontrolled diabetes, so what happened to the socket? The healing will be very poor. So we don't want it to affect the treatment outcome. That's why the patient needs to be fit and healthy first. Second is we assess the patient whether really needs or not. For example, like this case, patient wants to build up the self-confidence, wants to go for interview, or sometimes the politician will come or the singer which needs the teeth immediately. So that's why we indicate for this type of immediate dentures, but not for everyone. Okay, because it also involves extra visits. When we do these immediate dentures, normally after we issue the dentures, After 24 hours, next day, the patient will need to come back again to review for the socket healing. So some of the patient, if it's very difficult to come to clinic, this one might not be suitable. Okay.
I see. Excellent.
Yes.
Thank you so much for answering that. With that, we end the first case and let's move on to the second case. So
Right.
for the second case, doctor, could you please describe the case?
Okay. Second case, now we move the focus. Just now, the focus is hypodontia, right? Now the focus is more to perio actually. Okay, periodontal. Okay. I've chosen this case because this is quite interesting and it's unconventional, the treatment. So we have a 44 years old male who's being referred by the GDP to our hospital. Basically, patient is fit and healthy, okay? And the patient is a regular attendee. So before this patient has received a full course of periodontal treatment already, which include the non-surgical management, oral hygiene, and also full mouth scaling and polishing using full mouth disinfect approach with systemic antibiotic as an adjunct in the hospital. So that means this patient has already done the full course of the periodontal treatment. So it's referred to us because of the complaint. Okay, what is the patient's complaint? The patient complained the mobility of his upper teeth and he feels that it's progressing. That means it's getting worse every day, the mobility. And also there is slightly gaps that between his upper anterior teeth. That means he feels that it's very ugly already because a lot of gaps here. And he also pain on biting and fear that he might lose his front teeth. All right. So history of presenting complaint is he noticed the gap is getting larger and the teeth are getting longer after the full course of periodontal treatment. Okay. Let's look at the photo before the periodontal treatment because the GDP that's referred to us actually sent his photo, okay, before the periodontal treatment and after the periodontal treatment. So you can compare these two photos here. You can notice that first the anterior teeth are actually become longer. Why does it happen? As the gum healing is going to shrink down because the inflammation has gone. So once the inflammation gone, the gums are shrunken. That's why it exposes more of the tooth or the teeth. Okay, so the teeth will look longer. And as the gum is receding, then the gap is getting bigger. Okay, so that's what happens. So we explain to the patient, then he can accept it, all right? But he requests us to do something without extracting his tooth. Okay, let's look further now. So we understand the situations. So we do the intraoral and extraoral examinations. So extraoral examination, again, there's nothing. So everything normal. Intraoral, at the current, when you sit on our chair, the gingiva is healthy, firm, and pink in color. That means most likely the perio has become inactive already or is healing. And localized recession noted on 1-1 and 2-1, exposing 1/3 of the root length. Okay. Furcation, no, we don't see any furcation. Suppuration, also no. Oral hygiene is optimal, quite clean, no calculus. All right. But we notice when we do perio pocket charting, there is pocket generally between 5 to 9 millimeters still. Okay. Then the tooth position of 1-1 is shifted, leaving a big gap between 1-1 and 1-2. So, and then we also noted there's occlusal trauma. Okay. 1-1 and 2-1. You can see the photo here. It's a lateral view. You can see the lower anterior is hitting against the upper incisors. 1-1, 2-1. So each time the patient occludes, what happens is it will splay open the upper anterior teeth. How you do examinations, whether got fragmitas or not fragmitas, is occlusal trauma due to, let's say, for example, if the lower is too over-erupt and it's hitting on the upper teeth. So what happens is we put the fingers on the labial side of the anterior teeth. Then we ask the patients to bite. When in your fingers, you were able to feel the teeth is actually knocking your finger. So that is sign of fragmitas. All right. So we need to solve the fragmitas problem because if we don't solve it, then what happened to the bone? The bone will keep on reducing because it's trauma still there. Okay, so the perio won't be good. And we also noted there's mobility of grade 1 on basically 1-1, 2-2, 3-1, 4-1. And grade 2, 1-1 to 2-1. Okay. PPE score generally still score 4. Special test, we did a vitality test for 1-2, 1-1, 2-1, 2-2, 2-2 as control. Okay. EPT show all the teeth are still whiter. Even though it's already dangling like piano keyboard, but it's still all whiter. So radiographic now, we took a DPT. So this DPT show horizontal bone loss involving half to 2/3 of the root length on upper teeth, and then 1/3 to half of the root length on the lower. So irregular bone loss. So vertical bone loss noted on 1-3 mesial, 3-4 distal, and 4-7 distal. So you can see the pattern of the bone loss is on the posterior, on the first molar, and also majority on the anterior teeth. So what perio conditions can we always think of that? when the bone loss is on molars and around the anterior teeth regions, we always think of aggressive perio. Okay, but then you will tell me aggressive perio, normally this is juvenile. It is supposed to be happening in childhood. These are the very typical case that previously juvenile has aggressive perio, didn't get any treatment, but this thing followed the patient until old age. So we just managed to catch the patient during that time when he's in 40s. So that is his history previously is aggressive perio. The reason why it become like this, all the heavy bone loss. So we come to the diagnosis. After we have all this finding again, it's a localized non-inflammatory periodontal pocket. The reason we say non-inflammatory is when we do pocket jutting, there's no bleeding. That means the perio already stabilized already. It's just the remaining pocket is still there because first the bone loss has been extensive. So it's very difficult for us to reduce the pocket depth. And occlusal trauma 1121 parameters.
So the first question, what's the cause for the mobility of the anterior teeth followed by localized recession and pain upon eating? Was it due to past dental trauma or malocclusion?
Yes, that one actually I already answer part of it because yes, it can be due to a lot of reasons. One of them is juvenile or aggressive periodontitis. Another one is maybe due to the patient's habit. For example, patients like to bite on the anterior, or there is some major trauma happen to the anterior teeth during the patient's lifetime before come to us. Because you're judging from the oral hygiene, patient is quite well motivated, but it's clean, and then patient is a regular attendee. It's unlikely due to the when patient not cleaning properly. Okay, not the conventional perio. So most likely it's due to localized trauma or history of juvenile aggressive perio that caused the problem.
I see. Thank you, doctor, for explaining. For the second question, from the x-ray you provided, it seems like the bone loss for the anterior teeth is quite severe. How will you approach the treatment plan for this patient, and would it be better to go for an extraction followed by RPD?
Yes, that's the good question. That's always, when you want a quick way, yes, I agree with your extract, and you maybe do a prosthesis over it. That's the straightforward case. But unfortunately for this patient, because this patient has gone through so much visits to get the periodontal treatment done, and then patient is highly motivated. So when he came to us, he expressed that he wants to retain the teeth. Okay, so what can we do? The patient wants to retain the teeth. So in this case, what is actually the treatment plan that we give to the patient is, first, of course, we still reinforce the oral hygiene. That means tell the patient you need to keep up with the cleaning and everything. Secondly, because you see one of the diagnoses is occlusal trauma. Okay, so we need to eliminate the occlusal trauma. How? Because you see each time when the patient bites, when the lower teeth is touching the upper place, right? So the easy way, people straight away will think, okay, let's trim off this one. Okay, you trim off so that they are not touching. But you have to remember when you trim off, what happened? There's a gap, right? Then the lower teeth will continue to erupt, and then it will start again the problems and the occlusal trauma. So in this case, what we do is first we spleen the lower teeth first to prevent it from over erupt. So what we do is we use the orthodontic wire. You do internal splinting on the lingual side of the lower teeth, canine to canine. So we put the orthodontic wire to prevent it from over erupt. Then we spleen the upper. So because you see the upper keep on splaying. So what we do is we do a composite splinting on 1-1 and 2-1, followed by a composite build-up to make sure that it's aesthetic. So if that happens, then only we trim off the interference. So now we spleen the lower already, so the lower won't over erupt and cause further trauma. So after we do all the composite build-up to make sure that it's in good proportionate, because now there's a lot of gaps. We're trying to close as much gap as possible, but we cannot overdo it. Because there is no bone support left, and then if you overdo it or you over contour the tooth, what happens? It will cause plaque retention. We don't want that to happen because now patient is able to clean the mouth properly. But if our prosthesis is causing plaque retentive, then it's not good to the patient's treatment outcome. So we build up the contour, and then we do a gingival veneer. So you can see this photo here, pre-treatment. The gap is still very huge. The tooth is still very long. And then on the left side, you can see the post-treatment photo which already we built out composite. We spleen the upper 1-1 and 2-1. And then there is still a gap there between your 1-1 and 1-2. And also your interdental space. Okay. So therefore, we will give a gingival veneer. If you look carefully, the gingival veneer, actually we incorporate 1-2 on the gingival veneer. And then so patient just click into the mouth. It will occlude the space, the gap in between the 1-1 and 1-2. And also close up all this interdental space. So patient is very happy with the outcome. You can see the last photo when patient is smiling so wide. Okay. So patient is very happy, and then patient now currently still continues to review, come to us to review the oral hygiene, and also we make sure that there is not causing any further damage to the remaining tooth. Okay. All
I
right.
see. That's a very good treatment plan. Thank you for sharing with us. As an undergraduate student, gingival veneers are not really covered in our academic curriculum. So, Doctor, do you mind explaining the process of placement of gingival veneers? And if bone reconstruction is available to improve the bone loss and to recover the recession, will you still go for gingival veneers?
All right, let's talk about bone graft and gingival advancement flap. For certain cases, if you ask a periodontist, they will also maybe sort of agree with me. Not every case show success rate. If you do bone graft and periodontal advancement flap, they have a strict case selection criteria in order to increase the success rate of this type of surgery. So for this case, why I still choose gingival veneer over the other surgical options is first, it depends on the patient. So if the patient is not willing to undergo any more surgery, or the patient's medical health is not permit to do all these surgical interventions, most likely these removable prostheses will be the good options. However, not every case or not every patient also can be given this type of prosthesis. First and foremost, patient needs to be motivated. That means the oral hygiene is tip-top, and the perio status is already stabilized. Or else it's going to worsen because all these gingival veneer is a plaque retentive factors. That means plaque will come and accumulate over there and it will worsen the remaining tooth. We don't want that to happen. Instead of retaining the tooth, you just shorten the lifespan even more. And one good thing about this splint is, because you remember just now the tooth is very highly mobile. So what happens is, if you put a gingival veneer on the labial surface, what happens is it will also act like a splint to prevent the teeth from splaying each time patient biting. For example, patient are biting maybe chocolate or chewing gum. So when it touch, it will splay. So with the gingival veneer, it will stop or reduce the amount of splaying of the anterior teeth. So that is the benefits and why we give the gingival veneer to the patients.
I see. Thank you, Doctor. And that's all we have for our case-based question for today.
Okay,
and before we end the video, let's get into a bit of fun. We have a few questions for this rapid fire round. I will be asking you 10 questions, and all you have to do is answer as quick as you can.
Okay.
Okay. All right, let's get started. The first question is, if you could have any superpowers, what would it be?
Superpowers? Make more money.
That's I think the superpower everyone would also want to have. Okay, so for the second question, what's your favorite dental procedure to perform and why?
Favorite dental procedures are taking impressions. I don't know, I just feel very comfortable doing the procedures. Maybe this is my bread and butter. If you ask an oral surgeon, they will say pulling out teeth. All right.
To be specific, is it primary impression or secondary impression?
Doesn't matter. Sometimes it's fun to see patient. No, I'm just kidding. Okay.
Okay, so for the third question, what's the best piece of advice you have ever received?
Best piece of advice: settle down and get adapt. Okay, don't think too much, because I have the problems like I'm very anxious if going to new places and all those. So that would be the best advice for me.
All right.
Yes.
Interesting.
Yep.
So the next question, what's your favorite dessert?
Favorite dessert? Anything sweet. Anything sweet is it? Favorite dessert?
So you're a sweet tooth.
Yeah, sweet tooth, very.
Okay.
Yes, anything sweet.
Okay. The next question, if you could speak any language fluently, which would it be?
Thailand, Thai. Because I live in Kelantan, and I have friends.
It's very close.
Yeah, it's close, and I have a lot of friends from Thailand last time. Because they come, they are actually studying the same school as us in Kelantan. They purposely come to Malaysia and study our curriculum.
So you know a bit of Thai?
A little bit, but not too much. But I still cannot communicate with them properly, because and then Thai language, there's a lot of different province, different type, different dialects. So the one that we always exposed to is the southern one. So it's a bit different for Bangkok, the Thai language.
I see. Yes. Okay, for the next question, if you could time travel, would you go back to the past or the future?
Past.
Why?
The best moment is actually in UK when I'm studying my master's. So that is the most stress-free, because it's so far away from your country, your family. So all their problem is not my problem. No, I'm just kidding. So you are secluded and very happy. All right. So that would be the happiest moment.
Okay,
go back to
nice. Okay, the next question. What's your favorite thing about yourself?
Can eat.
So, doctor, you can eat a lot.
Yes. But not, actually nowadays, not much already. Maybe aging good. Last time we like, last time when I was in undergraduate, we used to go to buffets and all those, but now we can't do buffet anymore.
Oh.
Yes. So that's what I enjoy the most now, which now is sort of depleting.
Okay, interesting. Okay, the next question. If you weren't a dentist, what career would you pursue?
I want to be a tour guide.
Because you like traveling.
Traveling, yes, a lot of traveling and a lot of explaining. That's why I'm how to say, I'm considered tour guide from my hometown, no, Kelantan. No? Each time my friends come to Kelantan, I become the tour guide and bring them around.
So next time if I go to travel
Can?
to Kelantan.
Most welcome. I can explain this building come from where, this road come from.
Okay, very interesting. Yes. So the last question, if you could change one thing about the dental industry, what would it be?
Change. I never think of changing the dental, no? But it's more to improving.
Improving.
Yes, improving. No? That means what we want for the dentistry nowadays is safe, convenient, and cheap. The most important is cheap, right? So if we can improve on those three aspects, then dentistry to the public now will be a much better place.
That's very nice. Okay, so that's all we have for today's episode. Thank you everyone for watching, and not to forget, thank you doctor for joining us and sharing with us all these interesting cases. I'm pretty sure the audience and I have benefited a lot from doctor's insightful knowledge. And with that, we hope to see you again on the next episode of Case-Based Learning. Thank you so much.
Thank you.